Firstly, thank you, Peter, for the invitation to be here at this Integrating the Healthcare Enterprise meeting on update on NPAAC electronic communication standards. I think we might go to the first slide, which is the acknowledgement of country. So we wish to acknowledge the traditional owners of the lands on which we are all sitting and their elders past and present and emerging. We recognise their care for these lands over the millennia. The agenda is I'm first. I'm just going to say some words on behalf of NPAAC, and then we'll pass to Derek, who will talk more about the standard and changes to that standard generally. He's the CIO of the RCPA QAP. Then Vincent will talk about implementing standards for pathology messaging, and then the next steps will be undertaken by Peter. This is the fifth meeting, I note, so I'd like to first of all congratulate Peter, Vince, Michael and Derek on organising this meeting and running it. These meetings are very important because of the importance of the topic that we're going to speak about, and it provides a real link between the standard and the implementation of that standard. As Peter mentioned, the attendance is really very, very surprising and very good for the organisers. There's 280 registrants at this stage, so that demonstrates there's a lot of interest in the standard and the broad area of trying to implement these messaging standards. And I think that highlights one of the issues that we've got with writing standards. You write something down, and all of a sudden there's been a change, and you have to modify what you would like to modify, in this case the agenda or the standard, because of new information that's become available. One of the problems with standards, and I'll elaborate on this a little bit later, is it's very difficult to do that. I should also, just going back to where I was, as well as the 280 registrants, which is represents a broad range of organisations and people. There are about 50 laboratories represented and over 100 organisations, so that's very good. But we should also say that, in fact, there's an international flavour to this, in that there are registrants from Singapore, New Zealand and Fiji. The purpose of the meeting, as you know, is really for you to learn more about where we're up to with the standard and where we're up to with the implementation, some assistance with the implementation, but it's also for you to provide feedback on your problems and concerns with the standard as the standard evolves. All of this really helps NPAAC and other people out there to ensure that the standard does continue to improve and that we understand and you understand the document. As you know, we use standards, humans use standards to reduce variation in activity and expectations, and we've used standards forever. It's probably one of the oldest professions that we have, and that is trying to standardise what we do, be that by weights or measures or documents or signs. We try and standardise those things so there is less variation, as I say, higher expectation, but also a greater understanding of what expectations are. And we really couldn't run our societies without standards. The role of NPAAC, and I'm here really representing NPAAC, is to reduce patient risk. So our role is to advocate for patients, and we do that by producing these standards. And the aim is really of the standards is for patient safety. And again, not surprisingly, by trying to ensure that everybody is doing the same thing to the same level, that is via a standard, we should reduce variation and therefore improve patient safety. Patient results, as you know, they really form the backbone of diagnosis and monitoring in modern medicine. So ensuring that those results, when they're sent to referrers or requests come in, ensuring that those messages and those inputs are all standardised is critical to ensure that there's no variation. And the importance of having the same format and structure of reports is key, and that's what we're trying to achieve, just so that when you see, as I said, it's like a sign, when you see a stop sign, no matter where you go around the world, I think these days all stop signs look the same, all giveaway signs look the same. The ideal would be that all reports look the same. I'm not talking about the contents, I'm really talking about the format and any abbreviations, etc., that we use. Writing standards is not easy. Anybody who's tried to write anything like this, like a standard, like instructions, knows just how difficult it is. It takes experts, and NPAAC use experts to write these standards. It takes them time to identify what risks we're trying to address, and then we have to get the language right so that people understand what those risks are and what mitigation they may need to do. So there needs to be practical solutions to the problems that are identified. And the standards, really, we don't write standards and then we expect the whole profession to follow. We write standards on the basis of what the profession has defined as best practice. And that's why we use experts to determine that. The NPAAC standards are slightly more difficult to produce because of the nature of what we work under, what NPAAC works under. We work under legislation that dates back to the 80s. So our standards are actually in law. Most other standards that are out there or guidelines that are out there aren't in law. Because our standards are in law, that means that they have to go through a parliamentary process before they can be produced. That takes longer to produce the standard. We have to go through a number of regulatory requirements we have to fulfill before we can put a standard out, and that's good because there are checks and balances, but it makes them more difficult to change as well. But they do need to be fit for purpose, and that is they do need to be relevant for practice. So the extensive process that we go through in terms of the document is prepared by one committee of NPAAC, goes out to public consultation, comes back to that committee. Depending on the level of public feedback, we might send it out a couple more times for public consultation, and then it goes to NPAAC Council for formal approval, and then it goes out there. So that process can take 12 months. There's particularly a problem with standards because of that long lead time and that process that we go through. There's a problem in any area where we're writing a standard if it's rapidly changing. So in areas such as anything to do with sort of genomics or genetics, and in this area of IT, where there's a lot of change going on all the time, it's a process that we use to produce the standards is not agile. So it takes us quite some time to make changes. And often changes occur that we don't expect. Just as an example, with COVID, we had some standards out there that we thought would be suitable for COVID, and everything was going really well until laboratories started to send messages to patients on their mobile phones to say what the result of the COVID assay was, and that's great medicine. But in fact, it took us a few months to come up with a standard for messaging to send those results to a mobile phone. So sometimes you get surprised. The InfoComm standard has produced a lot of feedback, and in fact, when we've done surveys, it's been voted our most unpopular standard. But we've tried to modify it, as bearing in mind that the restrictions that I've mentioned. And in fact, we've made some changes just very recently that you will see shortly. The changes really involve, firstly, alignment of the current standard with the new National Pathology Standard, which is about to be published. So we've aligned it, and that is to make sure that we're reducing any duplication. So that's been undertaken. The addition of the HL7 fire requirements with clarification from an advisory. So we're going to put out an advisory that will accompany this standard for the first time, just because I say we have limitations with standards. We're now going to adopt a process of using some advisories that will give a little bit more communication around what we're trying to achieve in the standard. That will come out, and we hope that will be useful. Any advisory is not part of the standard, so it can't be assessed against by NATA. We've also clarified some of the mandatory language so that that's consistent, and we've also included in this update to the standard an addition of artificial intelligence management system and a reference to 42,000 for that. Again, trying to maintain the standard so that it's still fit for purpose. The advisory specifically says that the current approved HL7 standards are HL7 version 2.4 and HL7.5, just to overcome that issue. Well, what seemed to us to be the major problem, which was that fire wasn't really mentioned. You will see those being published soon. But there are still problems with that standard. These are just fixes to, and the major fixes, the major sources of problems with that current standard. We're also going to start rewriting the whole standard later this year. So the process will start. We'll gather experts to review what we've got, and then go through the public consultation, or sometimes targeted consultation after that. So you will see more about work on this standard over the next 12 months or so. And we'll be looking for your input into that standard. And this meeting will also be very useful in that it will provide some feedback. I've noticed that you've also, people as part of the registration process, have made comments about what they expect to see or what they want from this meeting. So that's great, and we will use those in the feedback with this new standard. I'd also like at this stage to thank the Australian Commission on Safety and Quality in Healthcare, who actually do all the hard lifting. We write the standard, but the hard work is actually done by the Australian Commission, and they make these standards more usable, change the language so that it's more appropriate for the audience. They make them look a lot better than the old NPAAC standards did, and they do all the last minute changes. And I can't tell you just how last minute some of the changes are when we find errors in the standard. So I really thank the Commission for doing all that work. I'd also like to thank you again, firstly for attending the meeting, everybody who's out there registered for this meeting, because again it shows that you're passionate about what you're trying to do. You want to learn more to make sure that these standards work, because ultimately, as we're all we've all got the same goal, and that is to reduce variation and therefore patient risk. And I hope you can go away from this meeting with some or most of these queries answered. So thank you very much.
As I mentioned, I'm going to start with a quick summary of the accreditation process. Just look at a high level of some of the things that have changed in the standard as Tony had published soon. I note that the version that's up there is still doesn't have some of those changes there, but it will be published shortly. And then we'll move through the messaging standards and how the IHE and the tooling developed by QAP can help you meet those requirements. I know there's a lot of questions in the webinar questions about, what do we need to do? How can we actually do this work? So just a quick orientation for the mixed audience that we have today. Pathology accreditation has been compulsory in Australia since 1986. To claim a Medicare benefit, a lab must meet the National Pathology Accreditation Standards that Tony's talked about under the Health Insurance Act of 1973. NPAAC develops and maintains those standards. The one that matters for today, as Tony's mentioned, is the requirements for information, communication and reporting, and it's up to the 6th edition. That's the new one that Tony has mentioned. And we've got exactly one approved accrediting agency, and that's NATA, which assesses laboratories against those standards. They're using volunteer technical assessors, and keep that word volunteer in mind as it'll come back later. And that's what you need to be an accredited laboratory in Australia. So let's look at the standards that are produced by the Commission and NPAAC. There's a lot of different standards, but the one that we're focusing on today is that 6th edition of the requirements for information, communication and reporting. The purpose of that document really outlines how pathology information should be communicated between labs, requesters and consumers. And the changes that Tony has mentioned are around using the modern messaging and interoperability standards, including FHIR. The previous document was created before FHIR was widespread. So the new document is including FHIR in that. And just to note that the terminology that we're going to talk about, the low encoding and what SPEA, the college SPEA documents prescribe, is that terminology applies to fire. So this is not just, I'm going to use fire, don't worry about this. You still need to consider the terminology in the SPEA documentation. So I just want to start, I've used this example before, so sorry if you've already seen this, but I think it really highlights the problem that we're trying to address. So a GP rings a lab, more curious than angry, that every single one of his patients, young, old, fit, unwell, has a cholesterol of exactly 2.5 millimoles per litre. The same number, every report, statistically impossible and clinically absurd. So the lab checks its analyzers. There's nothing wrong. Checks the list, the results are correct. So where did the 2.5 come from? Here's the report. The result is 6. Okay. So nothing here failed, but everything was wrong. So here's the answer. The lab sent a cholesterol of 6 that was flagged high, but the receiving clinical system extracted the number out of a free text LDL target comment of 2.5 or lower and displayed it as the result. Every component in the system worked, and the analyzer worked, the LIS worked, the messaging service worked, the encryption worked, the GP software worked, that nothing threw an error. And the doctor was told, and a normal patient result was normal. And that's really the problem statement for this entire webinar. Delivery is not the same as meaning. So where did it come from? That cholesterol comment there. And the clinical system was extracting that out of the messaging because the code for cholesterol wasn't what it expected, so it went to do a free text search. So getting the right value with the right code, the right units and the right flag into the right field is interoperability. And that's what atomic data means. And that's why the standards exist. So within the NPAAC document, 2 conformance points do most of the work. S4.1, your HL7 messages must conform to ADRM 2021.1. And that's the Australian Diagnostics and Referral Messaging Localization of HL7. Long name and long document, and I'll talk a bit more about that. And you must be able to demonstrate it through testing. So that's important. Just remember that you need to be able to demonstrate that through testing. S6.2, when you send a report outside your organisation, at least one of the observational identifiers must be a SPEA low encode with UCOM units. There was a bit of confusion in the previous version of the standard that it kind of said must should. It's definitely must, and that has been updated in version 6 of the document. Just to be clear, you can keep your local codes if you need them, but the standard code must also be there, and so that any receiving system can understand that cholesterol is cholesterol in the right units, no matter which lab it came from. So what is ADRM? I won't go through all of this, just so that you've got a reference. It's the Australian Diagnostics and Referral Messaging Localization of HL7. It addresses HL7 orders, results, and referral messages for use in Australia and prescribes how those messages need to be displayed and what's in what position in the message. So ADRM is a 548-page document with roughly 300 technical points. So this is not an easy thing to do. If you search for low inc for cholesterol, so getting that right code for cholesterol, you get 169 candidates. Your scientists have to pick exactly which one matched on property, system, and units. And the SPEA reference sets that we've created exist to narrow that down so that you know which one to pick. Those tools are there to help. So those SPEA reference sets will tell you which code to pick. Underneath that, every LIS has got decades of local code, so that so this mapping process is genuinely expert work. The messages then pass through middleware and messaging repositories, where any hop can reshape them. And the hard bit is that you can't fully test a message alone. It renders in someone else's system. So the problems surface at the far end, and you usually get a phone call like the one we started with the cholesterol. And it's just as hard for assessors. Remember the volunteer component that I mentioned before. If we flip to the assessment side, NATA's technical assessors are volunteers. They're expert scientists doing this assessment alongside their day jobs. And we're asking them to assess conformance against a 548-page messaging specification, as well as all the other stuff that is in that NPAAC standard. So remember, this is just S4 that we're asking them to assess for against 548 pages. You can't eyeball a pipe delimited HL7 message and say it's conformant. I know a lot of people can read HL7 really well, and we've got people on this call like Michael Chapsky that could, but I'm sure he wouldn't say that he could read a message and tell you by eyeball all the defects that are hiding in all the different positions, the coding systems and the units. And he's an expert at it. So historically, there's been no shared test method. So what counted as evidence varied between assessments. And that inconsistency is a problem. We need to know that the same messages pass or fail no matter who assesses it. Hard isn't an argument against the standard, though. It's an argument for the tooling. If conformance is hard to judge by hand, then don't judge it by hand. So that's what QAP and IHE Australia and the pathology sector are trying to build together. First, it's the conformance profiles, putting ADRM and SPIA together encoded so that what is conformant has exactly one definition. The second is the validation tooling that we've built so that you can drop in a real order or result message and get a detailed report back, pass or fail, with references to the specific conformance point so that a lab knows precisely what they need to fix. And the third is the terminology support. So the SPIA reference sets and the lookup tools that pre-solve that 169 cholesterol low ink lookup problem so that you know which terminology component to use. The lab uses the report to fix its messages before the NATA assessment, and the assessor can then accept the same report as objective evidence on the day of the assessment. Vince is going to take you through what that implementation looks like, and Michael will demonstrate the tools. So I'll leave all of that detail to them. Before I finish up, I just wanted to say why it's worth it. So why put assessors and labs through all of this? Because standardized atomic data is worth it. If we look at safety first, a result renders correctly in any receiving system, and our cholesterol story just can't happen. If we look at continuity, coded unit safe results can be trended across laboratories and providers so that you can get real cumulative reviews instead of trying to read across PDFs. I was in hospital recently and had to look up my health record, and you've got to go into a whole heap of individual PDFs just to look at the trend and even have to remember across PDFs or print them out. That's not useful. And we want to be able to have safe, trended, cumulative atomic results. There's some issues to solve around what results can be combined, and I know the AACB is doing a lot of work in that space, and we really need to solve that issue, but we need to be able to release atomic results, if not only for public health registries, and I know there are several of you on the call that get these computable feeds instead of PDFs. COVID taught us the cost of all of that the hard way. We also need to use atomic results for everything that's coming next. The decision support, analytics, AI, dare I mention it, is only as good as the atomic data that's underneath it. If you've got an AI model reasoning over free text blobs with ambiguous units, it inherits all of those defects and uses those to make decisions that can be incorrect. So the unglamorous work of low ink, UCOM, and conformant HL7 is all the foundation of what we need to be able to achieve. So practical takeaways, if you run a lab or you're doing the IT work for one, do a gap. For the first thing, you need to do a gap assessment. So run your real messages against ADRM 2021 and SPIA using the tools that we've got, and Michael will show you those. Most labs are surprised at what they find. Number two, from the top of your test list, go by volume. So code out the top 50 or top 100 tests. Those cover most of your tests really quickly. Number three, validate and fix against the tooling report, not against opinion or vendor assurances. So look at the report, validate, fix, and retest. And number four, join the implementation program, and Peter will cover at the end about how you can do that. So the standards exist so that a cholesterol of 6 arrives as a cholesterol as 6 on every screen, in every system, every time. It's hard for labs, it's hard for assessors, and we've built this program so that nobody has to do it alone. We want one message, one meaning everywhere. So with that, Vince, over to you.
Thank you, Derek.
So I'm just going to give a very brief update about IHE and how this process has been running. We started a process back in the 21st of November 2024, nearly over 18 months ago, to put together a technical committee to go through all of the standards involved, NPAAC, the HL7 version 2.4 international standard, ADRM 2020.1, and SPIA, the terminology standard, to try and bring those things together to make it more accessible and put together tooling that will be able to test it. This is an overview of the IHE process. IHE has been established now for nearly 20 years. It's a well-described international process for putting together multiple different standards and using them in a coordinated way to achieve safe interoperability that is effective in achieving users' end results. So we're focusing here on e-requesting and e-results. The FHIR standard for e-requesting has been published, but there's no FHIR standard yet for e-results. So e-results in HL7 version 2.4 are absolutely key and will continue to be so for quite some time. So we're putting together those multiple standards and looking at collaboration between the laboratories, IT systems, communication services, and the clinical information systems. So part of the process has been testing conformant messages with desktop systems, both general practice specialists and others, and ensuring that conformant messages are actually processed correctly by those systems. We've tested 10 systems, and they all have been able to display the messages correctly. So, and we would be extending that program as part of our ongoing testing process. So IHE International has a vision of seamless integration and access to health information, and has been delivering that for quite some time. The National Health Record, IHR, is based on IHE standards. It's the IHE standard cross-enterprise document sharing, and they're implemented widely across the world. The process is backed by a large international organisation. The actual IHE methodology has been incorporated into an ISO standard, and IHE is an international standards development organisation. The usual resources are available on the web, and you can look all of those up for other IHE profiles, but in particular, we'll be focusing on the IHE profile that we put together of all of these standards to enable a testing process to take place in Australia. So we solve things by putting those complex standards together, as Derek has outlined, and specifying a way of testing them and a way of demonstrating conformance in what's called a plug-a-thon or a connect-a-thon, and then at a public showcase, so that people can actually see that the interoperability standards work in an end-to-end demonstration. So these are the work that IHE Australia has done in the past. We've done a diagnostic standard, a standard for the secure message delivery that was tested first in an IHE Connectathon, and a referral profile. So those have been over the last few years. So the IHE process is not a new one, and has been used quite extensively in the Australian marketplace. So we're putting together those key standards, the NPAAC requirements, SPEAR, the Australian normative HL7V 2.4 standard, and putting those together under the IHE International Pathology and Laboratory Medicine PALM process. And we've had one of the international co-chairs participating in the whole process. So this is a profile that will be an Australian localization of an international standard. It allows for fast-track development with workshops and peer group support, and conformance testing and interoperability testing that allows laboratories to say, yes, we are conformant. So they can then take that forward. So this is the process that we're running through, taking those Australian standards, putting them together under the IHE PALM umbrella, and then as part of that process, we've run a technical committee that's put together all of those standards into a single document, which Peter will take you through briefly, and that's been put together with testing tools developed by RCPA QAP, and we'll be putting those all into a series of workshops, peer support sessions, and testing events over the next couple of months. So look for that, and there'll be more about that as in the next few weeks. So with that, I might hand over to Peter.
Excellent. Thank you. So let me acknowledge RCPA QAP's role in assisting in practical sense with the progress towards standardizing pathology messaging in Australia. I'm very delighted to have been a part of this effort. We have a series of tools which QAP developed as well as resources. So let me go very quickly through, and then I will actually use the tools to very briefly run through them. We have a RCPA SPEAR lookup tools and resources. We have a downloadable requesting archive, which contains computer processable data sets. There is a reason why the expression computer processable is there. It's basically take what RCPA SPEAR team develops and turn it into JSON and tab separate value files, which are directly computer processable, where Excel spreadsheets are not quite as easy to deal with. We also have the same for the reporting data sets. So we have a zip archive with that. On the web page, there is, which we'll see shortly, there is a context and references, including a brief history of how we came to be dealing with this, something that Dr. Badrick has already spoken of to some extent. We also have a SPEAR-defined requesting codes, terms, and other metadata lookup application that allows one to look up codes and metadata for requesting, as well as for reporting, which is another web application. We also have message conformance validation tools, which Derek spoke of and which were mentioned before. There are three kinds, basically. The SPEAR coding performance reporter web app takes a message and looks at only those parts of the message which pertain to coding, orderable and reportable tests, as well as whether or not they are being reported on under the expected requesting code, as well as whether the correct specimen is used and so on. The QAP validator web application and the backend service, which actually does the real work, allows one to submit a HL7v2 message and get a validation report, which again, Derek mentioned, which gives the blow by blow, as it were, enumeration of the issues and why are the issues and what maybe can be done about them. Mr. Russell McDonald also contributed a collection of tools that can be used for generating and validating a variety of healthcare identifiers. We also developed a couple of conformant message generation tools so that one can look at an example message which is valid according to the expectations that a message ought to conform to. So we can generate a result message and we can generate an order message. So having come to this, let me stop looking at a slide deck and actually start looking at the real world. So this is a web application. Sorry, this is a web page that provides access to all the tools. So each of these buttons is an active element, obviously. So if I look at what's the SPIA tools and resources, it gets me to this section. If I look at message conformance validation tools, it gets me to this section, and so on. So looking at the lookup tools and resources, the first thing is what's in the archives. So the SPIA requesting has a 5-value set, has a computable version of the SPIA for requesting June 2026 edition. The reason there is a June 2026 is because the RCPA SPIA team updates these resources reasonably frequently, and RCPA QAP endeavors to update the tooling, which uses them as soon as practical after the resources are released. The reporting has a collection of different disciplines for which there are separate resources listing law codes, RCPA preferred terms, and so on and so on. So these are the contents of the archives. The content and references is basically a bit of a history, links to the different standards and guidelines, as well as a list of all the actual Excel spreadsheets, which are the sources for the different data sets that the tooling is using. So looking at requesting codes. So these obviously are public resources. You can access them anytime, any place. So let's say pick a coagulation profile. This is the metadata that RCPA SPIA provides for that particular test, including the SNOMED code that is recommended, the preferred term, as well as a bunch of synonyms, any one of which can be used in lieu of the preferred term, although preferred term is, as it says on the tin, preferred. So looking at reporting codes, here we have a slightly different story because there are a great deal more of them, but also there is a great deal more information shown for each. So let's say, for instance, pick alanine aminotransferase, and we see a number of things, including for this particular reportable tests, there is a reference interval or reference range defined in the RCPA in the RCPA guidelines. So this is a guideline. So this comes directly from the guidelines as a guide. It doesn't mean that you must use it, that I am aware of. You also have, because this is a numeric test, there is an indication of whether this particular test can be combined. And there is an extract from the guidelines which speaks to this as well. So there are some kind of aids to kind of trying to figure out what to choose for what. There are obviously a bunch of filters. You can filter by name. You can filter by any number of properties, and so on. So this is what this tool does. Then we have the SPIA coding reporter application. That's the one which looks purely at the coding, not a message structure, not whether it's the right kind of message. So long as it can find the places it's looking for, the codes, the terms with the coding systems and so on, it will do its thing. So let me pick one of those and let me pick one of this. It can accept multiple messages concurrently. You can look at results, you can look at orders, you have to decide which one you're looking at, obviously. So analyze, and a report gets produced. And let me shrink it so we can see it. So anything that's red means no, it's no good. In this particular case, we look at a SPIA specimen source. This code expects, or what did I do? Okay, what did I do? I did something. Okay, this code expects that that the specimen is serology. Serum.
Yeah.
So looking at these things, we can see which particular segments in the message failed in what respects. If I look at a different message, let me see, what message would I be looking at? Let me see at this one. Clean as a whistle. So there are some comments, to be sure, which can be turned off when generating the report, but everything is clean, the coding is good. Then we have the major validator. So here we choose a single file. Let's choose, say, this file. And we decide what we want to validate for, or what aspects of the message we validate, or what standards or guidelines we're choosing to validate. That takes a little longer because the message goes to the back end and gets run through. And it's quite a large message, as we can see here. And it includes a PDF report in this particular, and HTML report, as we can see here. The validation report looks like this, and the 3 ticks means it's all good. Because it's all good, there is nothing really to say, well, it's all good. But if we were to try something else, which isn't quite so good, for example, let's say this one, and we validate it, and we expect SPIA and reference intervals and units of measure and so on to be validated. We'll go away, come back in a few seconds. And we see, no, it's not so good. So we have 217 diagnostics. And the diagnostics are fairly well, they certainly refer to the problems. So this is a ADRM 21.1 conformance point, lots of zeros, 8, which is failing. In this case, it says there must be an OBX in OBX-OBR group, and there isn't one, right? I'm not going to sort of discuss this any further, but here is the diagnostics. Here is what they look like. One does need to have some understanding of HL7 to read it. One has to be able to go to the ADRM or wherever and look up more information if they want to. There is the issues with the RCPA SPIA. There are some issues with NPAAC.
Michael,
yes.
Would it be fair to say that we, as part of our education program, we'll be running specific sessions on the tooling and to give people an opportunity?
Perfectly reasonable to say that, but I know of no plans at the moment.
Well,
nothing planned at the moment.
We don't have any dates yet, but we are planning a number of education sessions. But I think we would have to move on after you've finished your concluding comments.
All right. So this is to generate a message. I'm not going to show this. It is to generate a results message, and that's pretty much it from me. People obviously are free to play around with the tools. There are user guides for each of them, which are reasonably comprehensive.
Hopefully we've been dealing with Q&A as we've been going in the chat, but if we may have to have a separate session for more detailed Q&A. But in terms of what are our next steps and what is available, there are a number of resources that are in the pipeline that will be coming soon in the next month or two. We certainly we've had some 50 or 60 pre-Q&A questions and more arising in the chat. So after this meeting, we'll be more than happy to entertain people's questions and to make sure that they are answered and made available. And at the end, after this, I'll be contacting everybody with a poll, in particular to help us connect with key leaders in each organisation, because while we all as individuals can do our part, ultimately organisations are going to need to change to implement the messaging and the terminology. So essentially, the new resources are the profile itself that Vince alluded to, that brings together the ADRM, SPEAR and NPAAC requirements into one overarching document. It doesn't reproduce all those documents, but it highlights things that where guidance is needed in relation to implementation of the standards, and it cross-references all these documents. So the profile will be an essential tool for people who are tackling message improvement. The validation tooling is now available, as Michael has shown us, and the link is in the chat. And we are also, as Derek mentioned, developing a support program for industry to help plan the system upgrades that are needed, and to manage and measure organisational progress towards achieving accreditation. This is the cover page of the actual IHE profile that brings together the international HL7 standard, ADRM, SPEAR, the two SPEAR areas, which are terminology, but equally the SPEAR report guidelines, which standardise the presentation. That's the PDF version we've been talking about in the chat. There's an example of the content pages as they currently stand the documents in its final stages of review, and then harmonisation of comments received from the members of the technical committee. I won't labour on this one, but this is just my simple analogy of a HL7 message. It is like a train with a number of carriages. The engine is, in fact, the addressing area and uses where the national codes and identifiers go into. There's a segment that tells us what is which patient are we talking about, and using identifiers. There's a segment that talks about what test was ordered, and then the results that follow that relate to that test. So it'd be full blood count with hemoglobin and white cell count and so on. And lastly, there's the caboose, which has the last segment in the document has the PDF or the e-report, and that's where the SPEAR guidelines for reports come in. So this just gives an idea of how the whole thing hangs together. In terms of actors, so things like report senders and report receivers, order placers. The system order placer is the HL7 term for a request. The order filler is, of course, the pathology lab that does the test and provides the results. And the relay application are critical in the Australian environment. They're our messaging and communication vendors who are the glue between the labs and the clinical systems. The profile's been written to segment the information. There's a lot of information, but so that laboratory systems can go to the parts that are relevant to them. Clinical systems can go to the parts that are relevant to them, and so on. So the document's been structured to try and help people not get lost in the detail. This is an example of an informative statement that deals with this issue, where in previous, in the ADRM, it was possible to send whole groups of HL7 reports in one batch, but for clinical purposes, that has been now disallowed. And so there's a statement then they're linked to the conformance statements that relate to how that applies to laboratories, how it applies to clinical systems. And this is an example of a conformance statement that then can be implemented in either tooling or in human assessment. And a key message is that we don't believe that for most laboratories this will need any wholesale rework of their messaging systems, certainly much less than moving. This is not moving to a new standard, a new technical system. It is really tweaking and standardising the current system, and how much changes there will really apply to how close the lab systems are currently to the standard. And the first part of any engagement will be the testing with the tools from QAP to see how far off the standard labs currently are. The terminology is likely to need considerably more work. While the labs are very familiar with terminology and have systems, they are often using local codes, and so moving to a standardised group of LOINC or a standardised group of SNOMED, which is what SPEAR is about, is going to take potentially some thinking, and to do that translation, recognising that these codes are designed, the SPEAR codes are designed for communication with external partners, and to some extent are not necessarily going to be required for labs to change internally. So it's about the translation from internal codes to standard coding for reporting. To help laboratories work out how to tackle this, we're developing a 5-stage maturity model-based pathway to message interoperability that talks about these levels, and it will be possible for laboratories and for assessors to objectively determine are labs committed to moving to adopt the standards, and then how far are they progressing down through the process to eventually achieving interoperability in production systems. So this is just the key points from a document that will be made available as part of our support of a program to support laboratories. The second area of support is testing and demonstration. We have the online tools that QAP have developed, but there will also be a need for labs and external assessors to review the report formats. It's currently not possible to automatically check the content of PDF reports against the SPEAR guidelines. And a critical part of testing is practical testing between lab systems and the GP systems or clinical systems, and that is done in a program called an IHE projectathon or connectathon, and one is planned if we have laboratories at sufficient stage of maturity to for later this year. It's a membership of the IHE domain, providing laboratories with technical experts from IHE and the QAP to help labs work out what is in their current state, and to discuss how strategies at a high level. So this is a one-off consultation. There will be access to this SMART model that we've talked about, and how to assess progress against that. We've got the testing of system to system, labs to GP systems in connectathons. There will be an education program on messaging terminology and tooling, and to support labs to use these for self-validation, and with the capacity potentially to link people in with the additional expertise and resources if they're needed. So more information about that will be flowing in the next few months. So I might pass back to Tony Badrick to close the session.
I just want to thank everyone for joining us today. I know I'm sorry that I haven't been able to respond to some of the questions. I think the settings on the webinar have meant that I haven't been able to respond to everyone. It would be great to address all of these questions. And I just want to thank everyone for presenting. I want to thank IHE and the RCPA, NPAAC, the Commission, and everyone who's had involvement with this. We've got a lot of problems to solve, but I think we're starting to get there. So thank you, everybody. Just to Melanie's question there quickly, the new NPAAC requirements, I believe, will be out this month, Melanie. So, so the messaging around the fire updates and the requirements to use SPIA will be in that document. So it should be on the site shortly.
The issue about the what the clients can and can't do is an important one. Certainly for we've done some preliminary testing with a range of GP systems support through with the help of HealthLink, and the preliminary testing shows that the standard messages according to the new profile are able to be displayed and certainly displayed by the clinical systems. We haven't, of course, been able to attest how they deal with atomic data in the test situation as yet, but that is likely to be an area where the GP and clinical systems will may need to revamp their systems as the use of the standard codes emerges. Of course, it doesn't have to be an either or. If the standard code is being used, then that can be factored into their internal mapping systems. But it's a good point. Whatever we do not certainly want to break or cause any disruption to the flow of reports and atomic data.
The one that I don't think we have an answer for is concerns about systems not being able to forward PDFs with pathology results as part of a referral message. There are two approaches to that. Firstly, there is already an existing IHE profile available from Standards Australia for referral messaging in version HL7 version 2, and that does deal with how to attach PDFs. So I would refer people to that and suggest that they should talk to their system vendors about actually implementing that standard. We won't be testing that as part of the pathology work, but happy to discuss that further if you can let us know what vendors you've experienced that problem with, and we can chase them up.
Yeah, I think it's also true that our key objective is to have laboratories implement the standards. That is what NPAAC requires. It's necessary for accreditation. The GP systems, the changes are not going to break the GP systems, and change will be done incrementally and in a way that that enables existing messages to be processed while the newer standards are implemented. So, of course, as any change, it will have to be a somewhat managed process, and that is another reason why we are setting up the messaging support program, so that issues like those and a common approach can be developed across industry to make those changes and to ensure that the clinical system vendors are included in the process.
It's also, I think, worth emphasising that the areas where laboratories have been struggling to comply with the NPAAC requirements are really more around terminology. The differences between their HL7 message structures and the standard have been relatively minor. and I think they are easy to adjust. But the terminology is actually where the pathologists have to engage with the process, and that they really determine what terminology is used. And also, as the terminology changes, that can have downstream effects that are difficult to know about in advance. So the terminology implementation, I think, is actually where there needs to be a significant amount of focus, and is certainly where the tooling is a great help, in that it will clearly point out where non-SPEAR terminology has been used in messages. And there's also tooling from the NCTS, from the National Clinical Terminology Service, that makes it much easier to map existing laboratory code sets into the SPEAR code set. So if people want help with that, we will be running a workshop in conjunction with NCTS, going through some of that tooling. At the moment, the tooling only supports taking a non-standard, local internal code set and mapping it into LOIC, mapping it into SNOMED. But the NCTS is also working on a similar tool for mapping into LOIC. So we will be running the workshops when that is available, which we believe will happen in the next few weeks. But terminology is definitely going to be a big issue, and very important in terms of getting it right before attempting to move to fire. Because if you're sending, it doesn't matter whether you're sending a fire message or an HL7 message, if the receiving system doesn't understand the terminology, it won't result in end-to-end interoperability.
Vince, there's a question from Kathy about the complexities of dealing with hospital networks and how to be involved in the process. Well, certainly we do have a number of hospital-based people involved in that. We do have a technical committee that anybody who is part of the IHE process is free to join. So one way...
I think we should also emphasise, Peter, that this current work is scoped for external communications, not not internal hospital communications, and not really, inter-hospital communication. It's pathology laboratory to receiving systems and for results, and from ordering systems to pathology laboratories for orders. That's the major emphasis. We have also included the ability for pathology laboratories to send orders to other pathology laboratories, and for pathology laboratories to be able to send results to other pathology laboratories. So the inter-laboratory communication is slightly different. It's not actually covered explicitly by the NPAAC standards, but it is by sort of implementation. But the requirements are somewhat different.
Yeah. Kathy is saying she's really talking about I think it's the pressure on hospital IT departments to look after many functions and obviously prioritization. But there's been many years of NPAAC has flagged for many years that these standards have been around for 2.5 decades. NPAAC has been flagging for a number of years that they will be implemented for external communication. The rubber has hit the road now in relation to accreditation.
If I can just talk to that, Peter, the NPAAC standards were in fact published 6 years ago. The industry was given a 3-year window to start implementing it before it became a legal requirement. And then when it became a legal requirement 3 years ago, again, a further window of 2 years was allowed for laboratories to indicate how they were intending to comply. They didn't have to be compliant at day one. They had to have a process for moving towards compliance. And that's really where this work is focused, giving the laboratories tooling that they can use to demonstrate where they are in a maturity model, and then develop a plan for how they can move towards full compliance. So that's really what the accreditation process is about. It's not, being compliant on day one. It's about having a process to move towards a compliance state.
But I think, in fairness to IHE and us and QAP, we're not the policemen for this process. We are here trying to help people do it as quickly as possible, cost effectively, and doing it as a group. If there is that train analogy can be used, this train is leaving the station now, and or it will be leaving the station soon. And now is the time for organisations who want to avail themselves of that support to focus on this issue. And while we have largely volunteers who are prepared to put a focus on helping industry do this, that specific focus can only last for so long. So, Kathy, I'd encourage you to give us a call if you'd like to have a talk about this issue. My details are on all the information, and we can link you into the program. Anthony Bell has made a comment on communication between the radiology information system and the analyzers and software. That is not within the scope of this profile. This is between laboratories and external referrers.
But I should point out that the HL7 international PALM profile, IHE international PALM profile does cover that. I've implemented some 60 analyzer to LAS interfaces, and many of the more recent ones from the major manufacturers are now compliant with that PALM profile. It does make implementation much easier, and having a standards compliant analyzer to LAS interface means that it's much easier to move from one analyzer to another. So I would recommend you have a look at that. It's available for free download from the IHE International website.
Lily Ewan has said hospital pathologists also need to send results and receive results from external sources. Absolutely. So this profile standard should help that.
Might be worthwhile to point out that in the complexity and difficulty stakes, the RCPA-SPIA conformance is probably the easiest to implement because it does not really require changes to message structures.
It's easy as far as the HL7 messaging is concerned. I think it's difficult in terms of laboratory internals and engaging the pathologists in mapping tools. So there's a question about the genomics, and genomics is another whole area that is increasingly becoming important in terms of interoperability, but it's certainly not in the current scope of work. So yes, that's I think going to be a whole new process if we're going to have genomics being messaged. In terms of the issue around molecular pathology, I don't think there's any reason why you can't send molecular pathology in an HL7 message. It's just that the coding for that has not been part of the scope yet of SPIA. So if you think that's an important issue, please raise it with RCPA, and we can, in conjunction with the SPIA group at RCPA, look at how that could be taken forward. It's not an area that I have any expertise in, and so I think that that needs to be a further discussion.
Vince, on the other area has been structured, that's come up in questions, is structured reporting. We haven't discussed that specifically, but I would imagine that a properly formatted structured report can be published as the PDF and delivered to the clinician in that structured report format. But I'm also making an assumption that the current standard would support the management of atomic data for that, although that's something we haven't talked about.
The atomic data for structured reporting is a really difficult process. ADRM 2020 1.1 does have some guidance for that, but I don't think it's been widely implemented. And really, I think that's still an evolving area. So yes, whilst the laboratories are providing structured printed reports, and a structured report can go into a PDF, how that actually is represented in an atomic message is not at the moment really part of the scope.
Yeah.
Well, there is, to be sure, a collection of information models published by RCPA's SPEAR team for a variety of uses.
There is, and
for the most
that,
part, cancers and things like that.
yeah,
But as I understand it, it's not widely implemented.
It's becoming more widely implemented, and certainly in cancer reporting, but it's mainly focused on text reports. So it doesn't really go to the level of how you then represent that as atomic data.
Question from Sarah Thornsteinson is about how to give edits to, she says, ADM requirements, but it looks like also potentially SPEAR. We will be providing people with an avenue for that. At one level, those who would really like to be involved in doing some work to make the changes that they would like to see happen can join our technical committee, but it's also possible for people to just ask, provide their requirements, and we can then determine, are they covered by the current standards or do they need additional work? And if they do need additional work, that can be, that list can be then looked at and prioritised. So, but we will also be publishing the making available the for as a consultation draft for industry for a short period the IHE profile, Australia profile, and we will be taking feedback from people on that, and then it's anticipated that the once that feedback has been processed, that the profile will go into a trial implementation phase for at least a year, where we will hold it stable, unless there is hold it stable to enable people to actually implement, and then and for us to gain then the experience of that implementation. So that's the process that we'd be following, and we'll outline that in further communication.